Ok, bueno, entonces cedemos primero la palabra al público presente por si gusta hacer alguna pregunta. Igual estará conectada la doctora Seritan y en el caso de la doctora Cindy Grieb, evidentemente nosotros elaboramos 4 preguntas al menos en relación a cómo se han implementado las cepas y si en dado caso iremos abordando algunas de ellas. Bueno, muy bien. Vamos a empezar son 4 preguntas relativamente breves en relación a la implementación de las EPAs, sobre todo en relación a cómo ellos han vivido esta experiencia, ya con barreras o factores facilitadores. Dr. Seritan?
I think I understood that. The question was barriers and facilitators. Thank you. So I can speak for our experience. The barriers are that faculty need to be willing to do the workplace-based assessments. You know, the form that I showed you, it doesn't take very long time, but it is extra. One thing I did, meaning in addition to the routine evaluations, one thing I didn't mention is they do this on top of other evaluation forms that they're doing. So faculty have to be motivated and sometimes need to be reminded to complete this evaluation specifically for the purposes of our area of distinction. So I would say faculty motivation, we don't pay them extra, so they are not reimbursed or rewarded in any other way, other than knowing that they are participating in a pretty innovative program. And in terms of facilitators, I would say we created this form, made it very easy, gave them a guide how to do it. But, you know, it is once again a very small program. It's not the entire residency program. And another facilitator was the fact that the entrustment scale that I showed you, the levels 1 through 5, were already used in the residency program. So we didn't introduce a new scale or something new to say, now you can do this extra scale, learning a new, like a new methodology to assess the learners. They were already using this, so they were familiar. So I think the faculty buy-in, the program buy-in, and the program leadership buy-in is very important. In our case, the program I developed with help from the Department of Neurology, faculty in psychiatry, but also the residency program director, so the faculty and leadership buy-in. That was important.
Ok, bueno, mientras les voy explicando un poquito lo que la doctora Cindy nos compartió en relación a los facilitadores. Ella menciona que en el caso de Canadá, afortunadamente tienen el apoyo por parte del Royal College y eso les permite que primero esté estandarizado a nivel de todos los programas de geriatría o de todas las especialidades y eso favorece que de alguna u otra manera las personas que están directamente en la formación de los residentes se involucren y implementen estas EPAs. De otra manera sería un poco más complejo. Asimismo, también esta parte del entrenamiento y la capacitación constante es lo que les apoya para poderlo llevar a cabo. Referente a la parte de las barreras, aquí mencionan que como no hay EPAs específicas para geriatría, sino que hay en diferentes áreas, por ejemplo, mencionaba hace un momento en medicina interna, en medicina familiar, o sea, se van subdividiendo, por decirlo así. Entonces, también un poco que lo que hace la barrera es esta parte de que todavía no se implementa como tal unas cepas de geriatría específicas para el pregrado, sino que se ve como parte de la atención en general. Y justo esta parte de, son bastantes evaluaciones y puede llegar a ser un poco cansado estarlas realizando de manera continua junto con las rotaciones. Ok, pasamos a la siguiente pregunta. Dr. Seritan, how do you see the use of EPAs contributing to improving the quality of geriatric care?
Thank you so much, Dr. Duran, for that question. And I really appreciate, I was desperately scrolling through my emails to find the questions. I think the EPAs are very important because the competency-based education model is focused on outcomes, not so much on the time that the learners are spending, on a certain rotation or a certain number of days or weeks or months. So this is very important because our patients, our older adults, are very complex, as you know, and often medically, psychiatrically, and neuropsychiatrically ill. So focusing on outcomes allows the learners to want to strive to do that extra step to provide good care. I should say, though, I should add that the golden, the golden standard for any education model or education initiative, as you know, is, does this model change patient outcomes, improve patient outcomes? And I don't think we are there with the EPAs yet. We have not yet shown impact. What we have shown maybe broad adoption, like in the case of Canada or the Netherlands or other countries. We have shown implementation, like successful small pilots like ours, for example, but we have not yet, to my knowledge, shown impact on patient outcomes. So there's still some more work there to be done.
En el caso de la doctora Cindy, ella nos menciona que justo a ella le gustaría que una de las EPAs críticas que deberían de estar prácticamente en todas las especialidades y subespecialidades es una relacionada con el edadismo, porque justo se ve la necesidad de mejorar esta parte de la calidad de la atención para las personas mayores y que no solamente quede en el rubro de geriatría, sino en todas las demás. Dr. Seritan, we are going to with the third question. From your perspective, which competencies are most critical to entrust in residences when caring for older adults?
This is an excellent question. Thank you so much, Dr. Duran, for that very thoughtful question. So I was reviewing the EPAs from the geriatrics, not so much geriatric psychiatry. We actually don't have them for geriatric psychiatry yet in the United States. They exist in Canada, as you heard. I think that of the geriatrics, looking at the geriatrics EPAs that exist, I think that assisting the patients and the families into clarifying goals of care and making care decisions is very important, while integrating the patient's values and their own beliefs and being culturally appropriate. And then also some important EPA or tasks that are more important for older adults than, let's say, for younger people are deprescribing, so providing a comprehensive medication review, as well as providing consultation to our other healthcare team members. Because in essence, as a geriatric psychiatrist or a geriatrician, you're always a consultant. You're helping other team members and work in interprofessional teams. One thing that I ask of my residents in the AOD you have heard about is the coordination of care. It's very important to be able to talk to the other providers, members of the healthcare team, and collaborate with them appropriately and timely.
Thank you, Dr. Seritan. Now we are finally with the fourth question. What lessons from the American experience could be most valuable for countries beginning to adopt EPAs in geriatric education and practice?
This is a great question also. So what lessons from our experience in the United States or from our local experience here? I think that it is very important to look at funding for programs and funding for the faculty. Even though faculty are intrinsically motivated, pilots like ours cannot continue to go on. They're not sustainable if there is no commitment from the programs or from, from your higher leadership. in your country or other countries, just starting collaboration and the willingness to collaborate across silos and across departments or across specialties. I think that is also very important. And then also collaborating with colleagues, like, meeting Dr. Duran through Dr. Ole Tenkate, and hopefully meeting in person one day and collaborating and learning from each other, because there may be some lessons that we learned that are helpful for other people, but also there are lessons that we learn by listening to other presenters. And I learned a lot from watching Dr. Grief's presentation, as well as participating in the EPA course, which I'm sure Dr. Duran can share with you, that there is an online course, EPA course, that can be easily accessed.
Now, with this question, we are going to finish the session. And yes, we start to collaborate with the implementation of the GP and the APAs for geriatrics in our country. Thank you so much.
Thank you so much for inviting me. It was a pleasure. Thank you. Bye.